Good afternoon, everyone. Today, we are very excited to have our friend and colleague from the State Department of Health presenting on antibiotic stewardship. If you recall, leading up to this webinar, we had sent out a survey and we received 20 responses. And so we're also going to be highlighting some of those responses to gauge the greater need. Today's webinar is about resources, information, answering questions that you might have. With that said, we are a smaller group, so feel free to unmute your line. Feel free to put something in the chat. I will be watching the chat. And if you're watching this recording and you have any questions or concerns, please do not hesitate to reach out. And with that said, Madison, I'll turn it over to you.
Thank you so much. As Laura said, my name is Madison Riojas. I am the pharmacist, the Antimicrobial Stewardship Pharmacist at the Oklahoma State Department of Health. A little bit about me and some background. I worked for 5 years at Integris Baptist Medical Center as an infectious diseases pharmacist before recently moving to the State Department to look at stewardship from kind of a different angle. So I'm really excited to be here talking about stewardship with you all, and definitely encourage any of you to reach out if you need any support or have any questions about stewardship. So for today's presentation, we're going to be talking about stewardship program resources that are available to you that I've been working on and are targeted for all of the stewardship programs throughout the state in all of the different facility types. We're going to look at the background of antimicrobial stewardship, and then we're going to look at the CDC's core elements of antimicrobial stewardship and how to identify gaps in practice and do a good gap analysis of identifying places where you can really grow your program. So to dive in and start with is talking about the why. Why are we talking about this, and why does antimicrobial stewardship matter? So I wanted to start out by highlighting some of the impacts of antimicrobial use. And notice that this is the impacts of antimicrobial use, not the impacts of inappropriate antimicrobial use, because adverse medication effects and all of the other complications can occur with appropriate use just as much as inappropriate use. So adverse effects being nephrotoxicity, bone marrow suppression, neurotoxicity, and the list could go on and on and on. But I really just wanted to highlight some of the really significant adverse effects that can be associated with antibiotics, as well as causing C. diff infection from suppressing that normal gut flora and driving antimicrobial resistance. So all of these components really do come into play whether or not the patient is indicated to be using antibiotics. And it really hits home why it's important to make sure that we're limiting antibiotic use to just the patients that are really indicated and really have an infection that can benefit from treatment. To walk through a little history of antimicrobial resistance, I've put together this timeline. The source is cited at the bottom of the page, and that timeline from that source is much more in depth and calls out a lot more details. But I pulled out some of what I felt like were really good talking points from the timeline and put together this timeline. So penicillin is discovered in 1928, but it doesn't hit the market from FDA approval until 1945. By this time in 1940, we were already beginning to see penicillin resistance identified. So before it even is commercially available, we see that the bacteria are beginning to learn about penicillin and develop resistance patterns. The 1950s through the 1970s are considered the golden age of antibiotics, and the majority of antibiotic classes that you've heard of really came about in this time frame. But it's also the time frame that MRSA was identified, which is largely one of the pieces that was driving all of the innovation in antibiotics at this time. The 1980s brought along the carbapenems, which indicates there was some gram-negative resistance developing as well. The 1980s is also when VRE was identified. And if you'll note, it wasn't until early 2000 before daptomycin and linezolid were identified and were commercially available. So roughly 15 years went by between the identification of vancomycin-resistant enterococcus, or VRE, and an appropriate treatment for these infections. I want this point to really ruminate because this stretch on this timeline really represents lives lost and people clinically impacted and infections that we could not treat. And that's really important to keep in mind when considering antimicrobial stewardship and antimicrobial resistance, because the organisms that we're worried about now, some of these gram-negative organisms and carbapenem-resistant organisms, they're much more aggressive than Enterococcus, and as far as virulence factors go. And so if we run out of treatments and we get to a point that we don't have anything that can treat these infections, it's going to represent a larger swath of the population than the VRE issue did. So I just want to put that in your mind and at your focus when considering the importance of stewardship and why it's something really worth our efforts and worth our attention. So all of that was very historical, and to bring it a little bit closer to where we are now, the CDC started putting out antimicrobial or antibiotic resistance threats reports. The first report was looking at 2013. This identified that there were 2 million resistant infections per year associated with 23,000 deaths. By 2019, for the next report, 2.8 million infections per year were identified and 35,000 associated deaths. So as you can see, we definitely have been climbing. And then the COVID-19 pandemic hit. The 2021 to 2022 report looked specifically at the impact of COVID on these resistance organisms that we've been tracking specifically, and noted that there has been a combined 20% increase in the targeted antimicrobial resistant pathogens during that pandemic. 5 out of 6 of the targeted pathogens remained above pre-pandemic levels by 2022. So this is one of the largest spikes on this trend that we've seen, and it has not actually resolved. So COVID really kind of set back this movement in a lot of ways, in that there were multiple factors contributing to the increase in these resistant organisms, but now we're sitting at a space where we just see that many more of them, and it makes antimicrobial stewardship all that more important at this time. So there's all my warnings and my why as to why we should be focusing on stewardship. And now I really want to delve into the how. So I wanted to start out by presenting to you all some of the resource projects that I have been working on at the state level. One of those is the regional antibiogram, and we'll dive into that in good depth here in the next few slides. I also do facility-specific gap analysis and workshops. So if you have any questions about your program and you want my input, I am happy to meet one-on-one. I'm happy to meet with a handful of facilities if you're all under kind of the same umbrella. Whatever way that I can come in and help you build your program and solidify your program, I am happy to. So just reach out if you are interested in that. I also help with NHSN or National Healthcare Safety Network antimicrobial use and resistance data, whether that be getting your data live, understanding your data, troubleshooting why it's not working correctly, any of that I'm happy to help with, especially as that's become a CMS requirement and part of the Promoting Interoperability program. I'm sure that this is something that has been at the forefront of many of your minds. So if there's anything I can do to help you with that aspect, I'm very happy to. I have an infectious diseases and antimicrobial stewardship community of practice. This was initially targeted just at pharmacists, but there have been several infection preventionists, a couple of physicians, some nurses, just kind of a myriad of people that have been interested in this community of practice. So now it's kind of becoming a more general antimicrobial stewardship community of practice, but this meets quarterly, and there's a webinar with a CE associated every meeting. So if you're not currently getting an invite to that and would like one, let me know on that as well. And then we've just also been working on data-driven initiatives to identify and address health equity disparities. So as more and more data becomes available, looking at the health equity component, which is one of the reasons I was super excited to speak to this group, because I think that rural health is a space where health equity needs to be evaluated, because I think that sometimes you all get overlooked for resources, and we want to make sure that we address that whenever it's identified. So to jump into the regional antibiogram, an antibiogram being a compilation of pathogens and susceptibility patterns for a set time frame for a specific location. And these are really used to guide empiric prescribing, whether the pathogen is known or suspected. And it really helps identify the local susceptibility patterns and the likelihood that you're going to be able to treat that organism with the selected antimicrobial. This regional antibiogram has pooled regional culture data together to get a larger isolate number. What I really noticed when I took this role is that as I began talking to more rural facilities and smaller facilities, a very common issue was that they couldn't get enough isolates of anything other than E. coli to make a really statistically significant antibiogram. CLSI says that you need 30 or more isolates of an applicable pathogen to be considered statistically significant. And it's just really hard to get a large number of pathogens if you have a low volume of patients. But it doesn't mean it's any less important for you to know what the general trends in risk susceptibility are based off of those pathogens when one comes in the door. So that's really where this regional antibiogram is targeted to assist, is to come alongside what antibiogram data that you have available and to supplement from the region. So this is what is anticipated to look like. It's kind of going through some of the final channels to being publicly available, but the opening page will have a map with all of the different regions and allow you to identify where your facility is and what region you're looking at, what all counties are considered in that data set. And then you can follow to your specific region, and I have it broken out by urine and non-urine for the antibiogram. Then you can filter down to the specific pathogen and actually have the breakdown of just that pathogen or related pathogens. So some of the organisms I've put together into a complex, like the Enterobacter cloacae complex. So any of those subspecies that are similar enough to fall into that category. The reason I've put it in this format, and I will have the PDFs of each of the detailed antibiograms in a format that you're used to seeing available as well. But once I got this information, I noticed that it was very, very in-depth, and there are lots and lots of lines on the antibiogram, and it's a little overwhelming. So I thought that by putting it into this format so that you could filter and adjust, and just an interactive dashboard format might be more user-friendly, especially in a quick moment where you really just need to know, okay, I think it's E. coli in this patient, what are we looking at in our region? Or I think it's Pseudomonas in this patient, what are we looking at empirically in this region? So another resource, I mentioned that I've been doing a lot with the NHSN, AU, and AR data. So one thing that I'm working on to provide to you all as well is a de-identified interactive dashboard for the AAU data. This will allow facilities to compare similar facilities as far as size in the state. You won't know the specifics of the hospital name that you're comparing to, but for example, hospitals with less than 50 beds. You can compare across all of those different hospitals in a de-identified manner to identify if your facility is an outlier or if you're tracking with the general trend of the state. You can identify and evaluate drug-specific usage trends. You can see what you're doing and compare that to the statewide perspective. And then also, I know that your time is limited and many of you are wearing multiple hats. And so I want this dashboard to be an option to be a pre-built graphic so that you can filter down to just your facility, take those graphics to your stewardship committees and your P&T committees, and not have to spend your time building graphics to give that information. You can spend your time evaluating the data and not having to build visuals out of it. So that's kind of the end of the projects that I wanted to update you all on as far as the things that I have been working on. I now kind of want to dive more into the CDC's core elements of antimicrobial stewardship and really just talk about some options that you all have for building your programs and identifying gaps in the current programs that you're running. The 7 elements are leadership commitment, accountability, stewardship and pharmacy expertise, action, tracking, reporting, and education. If you've been on the CDC's website and you've looked into the core elements, you have probably seen that they have broken it down to multiple different avenues. There are core elements for acute care hospitals, there are core elements for critical access hospitals, for resource limited facilities, nursing home, outpatient, any facility type that you can think of, they have gone through and done core elements. For acute care, they've also elaborated with the priorities of core elements, and here they give kind of a more in-depth. So yes, you are tracking, but what are you tracking and what all are you utilizing? So that's really what these resources are. I know that critical access hospitals and other smaller rural facilities don't always have the same resources that a large acute care hospital does. But the core elements really are not intended to be prescriptive. They're more just intended to be evidence-based recommendations that have been shown to be effective. And utilization and barriers are going to be different from every kind of facility. So it's really about using this as a roadmap and setting the goal as to where you're headed. So leadership commitment. This is a really big one. And when you start looking at surveys and polls, lack of resources is really commonly identified as a top barrier. So if the leadership doesn't buy into what you're trying to accomplish with stewardship, then it's really difficult to move the needle and it's really difficult to get everybody else on board. It's really about creating a culture that supports stewardship in your facility. If the top believes in stewardship, then that will begin to trickle down through everybody else. Having a culture of stewardship that has pharmacists, physicians, nurses, infection preventionists, everybody thinking about stewardship and that being something that everybody cares about can make a huge difference in how well initiatives go over and how successful they really are. Accountability is about designating a leader or co-leader to champion the program. The literature really says that a pharmacist and physician team is highly successful. Physician having kind of that authority in that peer-to-peer relationship, whereas pharmacists come in with the detailed medication understanding, and it's a really good and very effective team. But that's not necessarily always available. Pharmacy leads are pretty common, but I definitely recommend empowering them if they are an available resource. But really just empower what existing personnel you have, whether that be the medical director, director of nursing, consultant pharmacists, infection preventionists, any of the nurses, anybody who's interested in stewardship and ready to really do the work of identifying where medication use can be optimized is really the best way to go. So it doesn't necessarily matter if you're infectious diseases trained. There are resources out there, stewardship training, certifications programs, just empowering whoever is passionate, and is just a really, I think, a good recommendation. As far as stewardship and pharmacy expertise, I have listed here several of the training programs and certificate programs that can really bolster your understanding of stewardship and some infectious diseases concepts if you don't already have that infectious diseases trained person working on your stewardship team. So I really would recommend any of these programs. The SIDP and the MAD-ID stewardship programs are targeted towards pharmacists, but the CDC training is open to any discipline. If you use a consultant pharmacist, whether or not they're the lead for your program, I really recommend partnering and really bringing in their expertise and tapping them for the resource that they are, especially if your leadership helps support them having time to focus on stewardship. And if you're not given time to focus on stewardship and you are the consultant pharmacist, I recommend really empowering everyone around you, making the whole group at the facility your task force for stewardship and helping provide this education, which we'll focus more on education on one of the later slides as well. So action. This is probably not necessarily the biggest component, but it's definitely the most talked about component, because it's what are you doing? Is it pre-authorization or restricting some antimicrobials to have the stewardship team sign off on whether or not they need to be utilized, like carbapenems, requiring a ESBL positive culture or a really good rationale as to why you need to pull out the carbapenem. It can be actions of prospective audit and feedback. This gets a lot harder if your stewardship lead is your consultant pharmacist and you're not there every day. And you're doing a lot more of like a weekly review. So I really recommend handshake stewardship in these circumstances where, as you're meeting with the physicians and as you're running into people, you're discussing the patients and what antibiotics they're on. Setting facility-specific treatment guidelines is another really important one. This is another one I think that there is a lot of potential for success, especially in small or critical access hospitals, because you can really utilize your ability to create an order set in your electronic health record and really funnel everybody through that order set. The order set then can provide education as well as guide prescribers down the correct and guideline appropriate paths for empiric treatment for community acquired pneumonia or urinary tract infections. With urinary tract infections, include the urinalysis portion whenever you're building these kind of treatment guidelines. Walk through when a urinalysis should be collected, and from that point when it should reflex to a culture. Create those barriers in the ordering process to cause prescribers to stop and pause and think about what antimicrobials they're prescribing and why, and whether or not they can give a good indication for what they're doing. This is just a really strong way to not have to be there and hand-holding the prescribers through the process, but to potentially also get really successful results. So I've also listed out in the next few slides are just some potential actions and some potential initiatives that could be implemented. And just wanted to walk through some of these opportunities. So one action could be revolving around vancomycin dosing. So the AUC over MIC dosing, or area under the curve per minimum inhibitory concentration dosing, was recommended by the IDSA in the 2020 vancomycin guidelines. This is great, but there are lots of barriers to implementing it. Obviously, the Bayesian and population models that are more predictive and prescriptive are the most ideal, because you have a computer doing advanced math and comparing to other patient populations of similar size and metabolism to help you make your decisions on dosing. But these softwares can be really costly, and it can be difficult to get into different facilities. Trough-based dosing is kind of on the other end of the spectrum. It's been the standard for many years, but it has many pitfalls, like the timing of levels, the turnaround time for getting the levels back, the consistency of changing dosing. Do you have a protocol specifically for that? So there's lots of barriers to both. And I don't know that vancomycin is ever something that anybody would say we've been doing phenomenally well in any facility type or size ever. So this is definitely a place that I encourage you to review potential options, because I guess the other question is, how does this fit into stewardship? But if you're dosing the vancomycin appropriately, you're more inclined to be able to actually treat that MRSA infection. So if you're appropriately treating MRSA with vancomycin and you're dosing in the most optimized manner, then you're going to have the most success of treating that infection, and you're not going to run into these partial treatments that could then produce further resistance. So definitely a stewardship metric. So some current options that exist, there is a Bayesian model partnership of DoseMeRx with ASHP Rural Health, and they have a package. And so that could be something to look into. SIDP has or the Society of Infectious Diseases Pharmacists has a toolkit. They have an Excel-based tool. It's not Bayesian or population model, but it does do that area under the curve calculation, which could potentially be a little bit more effective than just using trough-based recommendations. But there's always the opportunity for cumulatively derived vancomycin protocols. To have something very consistent across the state is an option. And if that's the best option, definitely feel free to reach out to me about maybe a group collaboration to develop that. Another action that could be considered is evaluating penicillin allergies. On this slide, I have a snip of an infographic that I put together. This will be available very soon on the OSDH website under the appropriate antibiotic use, and then you can download and print it and share. But penicillin allergies are a really big problem. 10% of the US population reports an allergy, but less than 1% of the population has a true allergy. I'm sure all of you have experienced this, of wanting to treat a patient with a cephalosporin or a penicillin and running into an allergy that then sends you down the path to meropenem or some other less ideal antibiotic for this patient. So penicillin allergy delabeling can be a really, really important initiative that makes a huge impact on patient care. This infographic focuses on the cross-sensitivity and cross-reactivity of allergies based on the beta-lactam structure. So beta-lactams, the R side chain, if there is similarity in that side chain, there is a much higher likelihood of cross-reactivity between two antimicrobials for an allergy. But if there is not similarity, there is very, very little chance of that cross-reactivity. So evaluating patients' allergies for whether or not they can use, for example, a penicillin allergy. Most cephalosporins are just fine and don't have any of that cross-reactivity issues. So along with this chart or this infographic, there's a chart that you can access that allows you to kind of match the antimicrobials together to see if there's cross-reactivity or not. Additionally, I just wanted to list some of the tools that you could use for implementation of addressing penicillin allergies, whether that be cross-reactivity charts, education tools. There's also PenFast scoring, which is a score that you can walk through to identify how likely a patient is to have a true allergy based off of how they reacted in the past and what their reaction was. Creates a scoring system that then identifies how likely they are to have that allergy, or if you can really go about through the process of delabeling that. So we've walked through several potential actions or potential initiatives that you can be doing at your facility, and now it's time to track them. So these are some of the standard tracking recommendations. So whether that be days of therapy or the antibiotic days per 1,000 patient days, there's also the NHSN reporting that you can be tracking, and there's the antimicrobial use module, which provides a standardized antimicrobial administration ratio or SAR, as well as antibiotic days and some other really interesting and useful information there. And this is really a useful tool because it's comparative across the rest of the nation. So everybody's data goes into this pool, and then we identify what everybody's doing across the country. So this really helps with standardization of data and really identifying where you're an outlier versus not. You can always look at outcome measures, tracking adverse effects. As I mentioned before, adverse effects is a huge component of antibiotic use and antimicrobial use. So looking to see what kind of adverse reactions you're seeing and how many, and is that decreasing with decreasing antimicrobial use. You can track C. diff cases and how they track with inappropriate antibiotic use versus appropriate. You can look at the antimicrobial resistance module through NHSN. This is actually going to help you track how many resistant organisms you're seeing. So it's really useful to pair some of these AR reports with your AU reports. So for example, if you're seeing a lot of meropenem, you can look at your AR reports and see, okay, but how much ESBL are we seeing? And if those numbers don't really match up, then you need to start looking into, okay, well, why are we using so much meropenem if we don't have much ESBL? So the AR module can really help identify where your efforts might be the most fruitful. And then there's always the financial impact. Cost savings are not the goal of stewardship programs, and I definitely want to make that clear. However, if you use less antibiotics, you do save money. So you can use cost savings as a surrogate marker to identify decreasing utilization of unnecessary antimicrobial therapies. And then there's quality improvement process measures. So all of the actions that we talked about before, tracking the acceptance rates from prospective audits or the adherence to using the guidelines and the order sets that we talked about, or a change in practice based off of education about penicillin allergies. Whatever you're doing, I recommend tracking the impact that it had and the uptake of your initiative. But what is tracking if you're not reporting it? It's really important to have regular facility-specific updates. Keep your prescribers, pharmacists, nurses, leadership in the loop. Keep everybody in the circle and identify where you have problems. Identify what initiatives you're going to be doing and the impact of those initiatives. Reporting keeps people engaged and it increases buy-in. Use the opportunity to share national trends and regional trends and really compare how your facility's performing up against some of those trends. This also gives you an opportunity to really discuss successes and challenges. And when you have everybody at the table and you're consistently keeping everybody in the loop, then you're going to have the best information and you're going to have the best feedback as to how to overcome some of the challenges and barriers. And then education. Education is key to changing the way that we prescribe antimicrobials across the board. There's lots of different forms that you can do education, whether that be presentations, webinars, looking specific for targets at your facility and educating on hot button topics that really apply to your prescribers and your facility. Handouts and posters are great. Just plaster your message everywhere. There are national campaigns that you can be a part of, which I definitely wanted to bring up today. So US Antibiotic Awareness Week is an example of one of these national campaigns. The CDC hosts this every November on the 18th through the 24th. So that's going to be coming up on Monday. And I do want to go ahead and throw out there that if you get involved with your facility and use this campaign as an opportunity to educate your facility and your practitioners, if you do anything, send me pictures or send me information about what you did. And that way I can really showcase what you all are working on and showcase what Oklahomans are doing to really change the narrative and bring information and bring awareness to the issue of antimicrobial resistance and antimicrobial resistance. The color is purple this year, and the theme is Fighting Antimicrobial Resistance Takes All of Us. And it's really geared towards this hands-on idea that everybody's voice matters when it comes to talking about antimicrobial stewardship. And then the last couple of slides are really just looking at gap analyses. So I really recommend taking the core elements that we walked through today, laying them up against your facility and identifying where you have gaps. It's a really great strategy to identify what you're doing well and being able to boost morale with your team of saying, we do a really great job at whichever of the elements, and then identifying, okay, but here is a place that we can put more effort, we can put more resources into, and we can really focus here. And then repeat the process. I recommend annually, but as often as is available and applicable. And that really helps you identify how those answers change and where the progress in the program has been made. It also helps keep you accountable and not letting slip the things that you were already doing good now that you've shifted your focus to something else. So all in all, antibiotics are amazing, but they do have risks like C. diff, adverse reactions, antimicrobial resistance, but everyone has a role in the appropriate utilization. And just because a facility has fewer resources doesn't mean that they can't absolutely thrive in their antimicrobial stewardship, especially when developing a culture of stewardship to boost the program. I've included some resources for links to the core elements, some of the priorities and implementing some of these core elements. So hope these are useful for you all, and I would be very happy to take any questions that anybody has.
I don't have any question, but I do want to tell Madison thank you. She has helped me in several of my rural facilities catch some things that weren't uploading correctly and just to be able to explain where we are in the position that we're in. And so I appreciate all of the work that you've been doing and that you have done.
Thank you so much.
You mentioned doing the gap analysis with facilities. What all does that look like? And what is the commitment to that with that?
So it really is kind of up to the facility. I'm happy to come, in person and meet with everybody. I'm happy to meet over the phone. Over the phone has been probably the most common. And I could just kind of have people talk to me about what they're doing with their program and what they feel like the biggest barriers and successes that they have are. And then we kind of walk through some of the core elements. And I know tracking and reporting is probably one of the biggest areas. I pretty much just provide some recommendations and some outside eyes. Sometimes it's really hard to see where the best place to move is when you're really close to the program. And so I just kind of come in as that outside perspective and say, consider this, consider this, consider this, and just am available as a resource or kind of just bouncing off ideas or whatever that really needs to look like for the facility. It's very, very flexible at this point.
Does anyone else have a question? While people are thinking, I do get a lot of AUR related questions. Can I place folks in touch with you as I receive those questions? And then also, do you have good examples of folks that are doing it well? I guess that's one of the questions I get a lot of. Who is a facility for us to look to in a rural area in terms of AUR?
Yeah, absolutely. And any questions you can absolutely send my way and put people in contact with me. I'm very, very happy to help with the AUR process questions and getting the data where it needs to go, and then how to utilize the data. As far as who is doing it well, that's kind of a difficult question to say. Honestly, once you get your data in, and validated and you're submitting, I would definitely say that you're in the group doing it well, because the second you start reporting and you start seeing what you have, that's really where the conversation starts. And so then at that point, it's just a means of identifying where you fall nationally. Once the dashboard is live, so that facilities can actually compare themselves to similar sized hospitals, I think that will be a very useful tool as far as looking to kind of examples, because from that point you can kind of see, okay, well, I don't know who Hospital 4 is, but they use less meropenem and more ceftriaxone than we do, et cetera, et cetera. But if there's any question as far as like how to do submissions well, I'm happy to help with the technical pieces of that and kind of walk through what reports are useful and how to really apply that to your facility.
Perfect. Thank you. I did receive a question in the chat via direct message. How do you gain access to see state and local resistance compared to an individual rural facility?
Sorry, will you repeat that?
How do you gain access to see state and local resistance compared to an individual rural facility?
Yeah, so the antibiogram will be a good way to see that. It will be posted to the website. The goal is here in the next few weeks, but I will be sending out communications when that is live, and then you'll be able to access that. And you can identify the statewide trends, and you can see regional trends, and you can compare that to your individual facility trends. As far as specific AR data, we don't have a dashboard at this point to compare that way, but I know that that's hopefully something in the pipeline. At this point, we're just able to compare the antimicrobial use data through that dashboard, which again should hopefully be live here very soon.
That sounds great. And I can also help forward it out to the rural health clinics and rural hospitals as well.
That would be great.
Are there any other questions? Well, if you get off this call and you get back with your team and you're like, I have a question, please reach out. I am happy to place you in touch. If you're watching this recording and you have any questions, please do not hesitate to reach out. Madison, thank you so much for your time today. And everyone have a great rest of your day.
Thank you so much.